a seminar on careers in governmental public health. I have no conflicts of interest to disclose, and neither does Dr. Richard Bruno. My name is Parul Chatbar, and I'm a PGY2 Preventive Medicine resident at UMass Chan. Today's seminar will be presented by Dr. Richard Bruno, MD, MPH, FAAFP, FACPM, AHIV-S specialist. He is the health officer at Multnomah County Health Department in Portland, Oregon. He is also on the board of regents with ACPM. He is a clinical associate professor at the Department of Family Medicine at OHSU and clinical associate professor at Floyd School of Medicine. He is also affiliate faculty with Health Systems Management and Policy at PSU. So that is our speaker today, and he is going to talk with us about the potential to explore careers in government public health.
Thanks so much, Parl. It's so nice to see you, and thanks so much for the kind introduction. And great to have you all here. This is really awesome. I'm really grateful to be a part of this conversation. And I was hoping maybe if you are here and you can chat, put in the chat your name and what organization you're affiliated with, and also what year, either student or resident or beyond, whatever sort of like level of your training you're at. It'd be great to get an insight into who's here today. But like Parl said, I'm going to be kind of talking about the role of governmental public health because that's kind of what I'm doing these days. And I'll kind of give you a little bit of a trajectory of where I've gone, throughout my career and kind of where public health has taken me through preventive medicine. And I'll start by just saying that I'm really just really so pleased with the work that American College of Preventive Medicine has been doing over the years. It's really an incredible organization. If any of you have been going to any of the conferences, the preventive medicine conferences, or have been involved in some of the work, it's really just an amazing place to really find incredible inspiration from so many. Such a heterogeneous group of people. I think it's unlike any other specialty society that I've ever been a part of or have heard about because it's such a wide variety of people doing pretty incredible work and have carved their own path, in public health and preventive medicine. So I'm always really inspired when I get to meet people at conferences or get to hear about the life path that people have been on because it really is kind of choose your own adventure. You really do get to kind of carve your own path and kind of make your own way. Now that's not to say that you have to do it on your own. I think it's really also part of the role of the organization is to support people through that to help kind of uh, tell them about the work that other people are doing that maybe sound pretty interesting or pretty similar to what you want to be doing at some point in your careers. So please use ACPM, and the resources for whatever purposes you need them to. And Anita is on this call and has been an incredible staff member who's just really so helpful and open to helping guide people to other folks that they may want to meet or connect with. And I'll say I'm happy to connect with any of you individually as well. So I'll put my email address in the chat as well, so you have that. So you feel free to reach out if I can be helpful with anything that you have going on, or if you're interested in learning more about this type of work in governmental public health. But I kind of came to this role uh, basically when I was in medical school. I had heard about preventive medicine, and I was lucky that I got to go to my first ACPM conference when I was a fourth year med student and get to meet a lot of these incredible folks in the field. And I had heard that there was a way to do both primary care and public health residency kind of at the same time. There were a few different residency programs that had either family medicine and preventive medicine, or internal medicine and preventive medicine, sort of as a combined residency program. And that sounded really efficient to me. It's like, oh wow, you can squeeze 3 years of family medicine and 2 years of Prev Med into 4 years, and you get your MPH, and they pay for it. I mean, sign me up. It sounded really good, and so I was really curious to be a part of an organization, a residency that really kind of helped foster that love of both public health and primary care, to create what we kind of call these hybrid docs that can do both, right? And so that was kind of my goal, is that I love seeing patients, I loved all my rotations, I love being able to take care of people, but I always felt like it wasn't quite enough. Like I felt like we always kind of needed to like think outside the box, outside the exam room, outside the hospitals, and really think about the situations that people find themselves in that really influence their health, and what we call like social determinants of health. It's kind of hard to influence a lot of those when you're just doing primary care or just doing interventional cardiology. So uh, thinking kind of like upstream, upstream, upstream. How do we find ways of either kind of changing policies or influencing policymakers to pull those levers and make those changes in society, make it easier for people to live healthier lives? And that really, for me, was why I came into this kind of combined residency, so I could help do both. So that I think is really what kind of got me on the path. So I did the preventive medicine residency at Hopkins, and it was combined with a family medicine residency at MedStar Franklin Square in Baltimore, and did my 4 years there. I did a national the loan forgiveness program, the National Health Service Score program, and so I had a 3-year commitment. So I worked at federally qualified health centers in Baltimore, and started learning how to do HIV medicine, addiction medicine, gender affirming care. And then COVID happened, and I became a medical director at one of the clinics, and had to get a lot of uh, set up for testing people for COVID, treating people for COVID, and vaccinating people for COVID. That became our kind of life, day in, day out, while also maintaining options for people to do telehealth for addiction, for gender affirming care, making sure people weren't falling off of their hypertension medicines and other meds, getting a courier service, delivery service from our pharmacy to deliver to people's houses. Those were the kinds of things we were working on, kind of standing up very quickly. And then got an opportunity to go back to Portland, Oregon, where I'd been in medical school, and I got to be a senior medical director for a healthcare for the homeless organization called Central City Concern. And so I oversaw two different clinics that were focused mostly on folks who are unhoused, people experiencing houselessness, and struggling with other problems like mental health and addiction. And so I was also a primary care provider, so continuing to use that kind of clinical skills while also kind of working on policies and procedures, and making sure that we could still see people nimbly within a very busy primary care clinic setting. We worked on getting a walk-in clinic going so that people who needed buprenorphine for opioid use disorder could get same-day appointments, kind of walk in and get buprenorphine with it's a very very low cost, low barrier, immediate access type of way. Um, and then worked really closely with my colleagues there to get a couple of mobile vans going to try and bring care out to the community, do that kind of street medicine in the field, and sort of meeting people where they are, as they say, to really try and bring that care to folks who had a difficulty going to a traditional brick and mortar clinics. So just kind of thinking outside the box, trying to take a look at the evidence that existed around the country for to do these types of things, and then just kind of implementing them, making them happen. And then most recently, I transitioned over to the Multnomah County Health Department in the greater Portland metropolitan area, about 813,000 people in our county. And as a health officer, which is kind of like a health commissioner, and you may have interacted with those types of folks in leadership before. Typically, they are overseeing public health interventions for the county that they work in, or the whatever health department they're in, whether it's a city or county or state health department. Typically, the health officer is going to be the one who is sort of a physician ambassador for the community. Oftentimes, they are working on policy on a county or whatever level they're on, and interfacing with the media, as you can see in the bottom left-hand corner, talking with the media about emergencies or outbreaks, or in that case down there, we had a heat wave that came through Portland with temperatures in the 110s, and we opened up some cooling centers around town to be able to provide people with air conditioned space where they could be safe. So that was me on the news, kind of explaining to multiple news stations at once, what the plan was and how we were moving forward, and being able to provide messaging about the fact that the last heat wave we had in Portland, we had multiple fatalities from folks who died from being in an unair conditioned space. And without people checking in on them. So my kind of high level message in those was, check on your neighbors, especially the folks that you are kind of fit the demographic of a sort of older person, may not have air conditioning, may not see them that much, but now is the time to go knock on their door, whether they live on your block or they live on your floor, and check in on them, make sure they have a plan, tell them about these cooling centers that exist, and help. We can transport them, to those cooling centers for free, and help them have a safe place to ride out that heat wave. So that was an example of something that oftentimes media is always asking, what's happening with this, what can we expect, and what are the sort of public health messages that you want to deliver to the community. So beyond that, we also do a lot of efforts through billboards, bus ads, trying to get a lot of social media going. And we have right now a youth-focused campaign for fentanyl use, because that is something we're seeing a lot in our community, is younger folks trying and using fentanyl and dying of fentanyl in our community. So we have a number of billboards through an ad campaign we're calling Expect Fentanyl, because if somebody hands you a pill, you don't know what's in it. Just expect that there may be fentanyl in that, and to be wary and cautious before considering using that. Also pushing a lot of messaging around having naloxone on you, learning how to use it. We have, and our health department has 9 school-based clinics that we run, and so we have a lot of naloxone and other safe supplies, condoms, and other harm reduction supplies at those high school clinics, so that students can get access to those types of materials, and be able to help out their colleagues should they need it. So those kinds of sort of upstream youth focus campaigns are really important, as well as having sort of like more downstream naloxone on hand for people. Um, Actually, while I'm kind of talking about that, I think it's really interesting to think about. Um, I use an analogy, sort of a metaphor, when I talk about public health interventions in general, and I sort of stole it from Camara Jones. She was used to be the president of the American uh, Public Health Association, and she's been an incredible advocate with ACPM as well. But she talks about a cliff analogy where, somebody can was doing okay, and then they kind of fall off of a cliff, and we have to have like ambulances at the bottom to like help people. And I sort of adapted that to the upstream. I sort of combined that with an upstreamist mentality. So I talk about sort of the river, and in this case, like the river of addiction, that somebody would like fall into a river, and they're addicted to some sort of substance, and then they may like fall off of the waterfall and have an overdose event, for example, and they may be drowning at the bottom of the waterfall. Well, part of our role in prevention is really to help uh, save people's lives at the bottom of the waterfall, right? We have to get more naloxone out there. We have to be able to throw people a life preserver, but that life preserver is really kind of made out of paper, because it's going to dissolve in 30 minutes when the naloxone wears off. So we really need to think about going upstream and really kind of putting up some nets at the top of that waterfall, so people aren't falling over the waterfall in the first place and overdosing. And those nets are really harm reduction supplies. It's access to medications for opioid use disorder like buprenorphine and methadone. It's fentanyl test strips and xylazine test strips, and all the things that can help prevent people from overdosing. But we really have to go even farther upstream, right? We have to go along the river's edge and put up some fences, so that people aren't falling in that river in the first place. And that's primary prevention. That's really working to help address early childhood trauma. It's helping people with healthy coping skills. It's working with law enforcement to get fentanyl off the street. Those are the kinds of like primary prevention that we also have to do as preventionists. So I encourage you to think kind of like on all 3 levels, right? Sort of primary, secondary, and tertiary prevention, and that really is thinking about how we can help people not to get addicted in the first place, and then for those folks who are already struggling with addiction, get into recovery and help them minimize any kind of harm that can come from it. So that's really an analogy I like to use, and you feel free to steal it. I think it's really helpful to kind of just conceptualize what we do along those spectrums. And for me, I really love to work on all three levels kind of simultaneously, right? Because any one area of intervention is necessary, but it's not sufficient, right? You have to have the kind of attack the problem at multiple levels if we're going to really have like a very concerted effort to address these very complex public health problems like addiction and houselessness. That's kind of one of the ways I like to think about this work. And I also, as Parl mentioned earlier, I also practice clinically in our HIV clinic. So I'd like to continue the work that I had done sort of post residency, learning about how to do HIV medicine while I was in Baltimore, and continue to work in our HIV clinic at the county as an HIV provider as well. Most of my time is spent sort of working on public health interventions, interfacing with the community. One of the things that I worked on recently in that bottom right hand corner is we pulled together a fentanyl summit. We had 200 people from community based organizations, government agents, we had law enforcement, payers, healthcare systems, people with lived experience, people with living experience, all coming together in the same room because we felt like things were very siloed. Everybody's kind of doing their own thing, trying to work on fentanyl or drug addiction in the community. We weren't always talking to each other. So I was like, all right, let's get everybody in the same room. Let's have a conversation. Let's hear from some of the experts about what the data says. Let's have hear from some of the folks who are on the ground providing counseling or trying to get people into treatment and recovery, and then let's break out into some smaller groups and tackle individual issues, like very upstream prevention, like housing, uh, like law enforcement, like recovery, and let's have these conversations and see where the pain points are in the community, and then from that we put together a report that we try to elevate these voices and encapsulate them into a report that we then elevated to the mayor, the governor, our county commissioner chair, the folks, those policymakers who do have those abilities to make changes in policy, and so being able to sort of be a conduit as well, be an advocate, be an ally for the folks that you're taking care of, the folks in your community, being able to bring their voices to bear and be an ally for them, so that we can make those changes that are needed to improve people's health and people's lives. And so those are kind of like the three big areas that I tend to think that we as preventive medicine docs can make a lot of difference. By being able to keep some clinical. Some of you may not want to stay clinical, and that's fine. But if you do stay clinical, I think it does give you some insight to that kind of one-on-one, needs that people have on the ground. But also thinking broadly about the population that you're serving and how you can be an advocate and an ally for them. Those are the kind of directions I tend to think that are really, really powerful, and you can do that in any kind of role that you're in preventive medicine. I like this governmental role because it gives you a certain amount of access to not only some of the large data that we have access to in a health department, but it also helps me interface, with different communities, be a part of the community, be on the ground, and not just sort of, sitting in an ivory tower, just like, telling people what I think should happen without having a lot of context and connection there. So I'll pause there for a second and see if there's any questions. If people are kind of wanting to think through any of this anything I've said mentioned so far.
So I did see a couple of questions.
Oh, great.
One in the chat and one in the Q&A.
Okay.
Um, so from William Capel, thank you for sharing your career journey. I'm really hoping to work in the public health sector after graduation. Based on your experience, do you find your primary care training helpful in your current role? Would you recommend double board certification to someone aspiring to work in public health?
It's a great question, William. I would say it, sometimes that you don't need it, and some places do prefer it. So it really kind of depends on what area of the public sector you're interested in working in. A lot of times, health officers or health commissioners like me will keep some clinical. Um, Now, one of my colleagues, my deputy health officer, she works in our harm reduction clinic, and she sees people in our STI clinic. So she helps kind of do testing for people. Um, so it's very kind of like very focused on like single issue, issues and problems, and that helps us, kind of keep our stethoscope warm, as they say. Keep us clinical and keep us seeing patients to some small degree. Um, if in my colleagues who are health officers in maybe some rural counties, they maybe do that very part-time, so they're mostly clinical, and then they will have like a, half a day a week maybe that they devote to, uh, doing some of the, signing off as a government official on official forms. I didn't really tell you about kind of my jurisdiction in our county health department, but I oversee the medical examiner's office that does like the death investigations, the emergency medical services, so all the ambulances, and oversee the public health emergency preparedness, so preparing for disasters and catastrophes and weather-related events. And then I do a lot of opioid work, as I mentioned. So those are kind of like my three domains that I kind of have carved out in our health department. And our health officer division is one of the five main divisions of the health department, along with behavioral health, corrections health, public health, and um, all the clinical. So there's like 17 clinics. I mentioned the nine student-based centers. There's also seven primary care clinics and the HIV clinic. So, and what I do is I tell everybody, I'm like sort of I'm your free consultant across the health department. So oftentimes I get asked to weigh in on certain things, even though I don't necessarily oversee all of those clinics. I oftentimes am pulled in to sort of weigh in about where we should go for extended release buprenorphine, for example. If we want, what they're trying to do right now is expand, access to Sublocade and Brixadi for patients who are struggling with opioid use disorder. So those are ways that I can use my skill set. Oftentimes I rely on my kind of primary care background and that primary care training that I received in order to help kind of weigh in on those. Um, but you can go to some larger cities where, like the DC health commissioner, for example, she doesn't see patients, and that's kind of like her choice is like she's wants to focus mostly on the population health side and doesn't really want to maintain the clinical, which is fine. I think it takes all types in the different environments really just kind of matter in terms of whether or not that clinical helps or not. Um, if you have the opportunity to keep some clinical, I think it's a good idea. I would say it's like always like you never know kind of where the wind will take you, and having like a skill set that you can rely upon in that with that clinical training can always be good to kind of fall back onto if for example you wanted to move out of that sector at some point and go back to just seeing patients. You always have that in demand skill set that will always be in demand. Yeah, hope that answered your question, William, and let me know if you will have further follow-ups.
That's wonderful. Thank you so much, Dr. Bruno. I have a question from Nathan Holterman. Hello, thank you for speaking today. What is your opinion on the job opportunities out there for those who will only be single board certified in PrevMed?
Yeah, yeah. So Nathan, I think there's still like a big need for folks who are just, have maybe done some clinical for a while and said, all right, not for me, want to do something else. Mostly just kind of population health based, and I think that's totally fine and needed. There's a lot of opportunity for folks to do what we call just kind of straight prev med or just pure preventive medicine. Uh, Whether it's public sector, private sector, nonprofits, there's a whole host of opportunities. And hopefully, and Nathan, I don't know where you're in your training. Let me see if you put it. Oh, okay. Oh, you're in Emory. Okay, great. So yeah, so obviously with the CDC in your backyard, lots of opportunities for rotations where you can really see the work that a lot of PrevMed docs are doing. And that's just PrevMed. It doesn't really include a lot of clinical. Um, One of my colleagues who's in the DC area, he works at the FDA, for example, for 4 days a week, and then he spends 1 day a week at NIH in their occupational health clinic there, seeing any of the scientists who may have gotten bitten by a monkey, for example. So he does a lot of ACMED, a lot of uh, you know potential exposures and things like that, and so he has to be kind of well versed on that clinically, while staying mostly focused on sort of the FDA processes that he's involved in. So and that's just simply because he wanted to, keep his clinical going and didn't want to abandon that piece. But you know, I would say there's a huge opportunity, a huge swath of preventive medicine career types that don't maintain clinical at all.
We also have a question from Alan Krita Olson. What are good starting public health positions after graduation within a local health department or health system?
Hey, Krita. Yeah, lots of good opportunities, I would say. And this kind of gets back to a little bit about like whether or not these jobs have a clinical component or not. But I would say, uh, as a if you wanted to just stay prev med, there are opportunities for positions like deputy health officers. Um, a lot of nonprofits need uh, either a prev med doc or an occupational health trained doc to oversee ACMED programs, whether it's at a nonprofit or a health system, for example. And so those are some kind of entry level jobs that people may kind of get right out of residency. Oftentimes what we see is that your prev med rotations that you're doing are great sort of job hunting exercise as well, because I can tell you, like, dozens of my colleagues who really love their rotation at a health department or in the federal government, or working for a union or a nonprofit, who ended up, working for that organization after residency. So kind of some on the job interviews that can happen too. And if you really love the work that you're doing, staying on with them and getting a job with them afterward is a very common pathway that a lot of folks take.
Oh, that's great. We also have a participant asking, um, so they said, thank you for your insight. Can you please throw light on how to, oh, I'm sorry, we already went. But can you please throw light on how to find public health or academic preventive medicine jobs? I'm not sure if those are listed in typical job portals or websites.
Yeah, that's a great question. So, um, one of the things I wanted to kind of mention, and um, one of the things we're working on at our health department, is this concept of an academic health department. So, teaming up with school of public health and a health department to really finalize and kind of bring these threads together for research, for rotations, for uh, working on projects together. So you have like the school of public health will have researchers, and the health department will have epidemiologists, and oftentimes they can work together on new projects. There's also, I think, a lot of opportunity for people for public health students to rotate through health departments and consider working in those environments someday. um, I will say, a lot of times on the academic side, you have a lot of folks who are really focused on trying to understand very complex public health problems, and that need a lot of data that is like held by a health department or some sort of government entity. So it's great when you can actually team up and work on or be able to connect data sets and with the analysis piece, and be able to publish and put out papers and present at conferences and things like that. I'll give you a really good example of something we're doing right now, a pilot program we have with our fire department. So our Portland Fire Department has a team that responds to a lot of the 911 calls for overdose calls in the community. And right now, there is um, a, that team will oftentimes go out and provide naloxone for people and reverse their overdose. But the paramedics on that team have a standing order so that they can also give people buprenorphine right away, which can help with not only the withdrawal symptoms that people get when they're put into instant withdrawal with naloxone, but it also helps reduce some of the cravings they may have to return to use for fentanyl. So buprenorphine is a great medication to be able to give people kind of right away. And so we base this on some research that had been done in Contra Costa, California, Camden, New Jersey, and Asheville, North Carolina. And we put together a pilot program that does a pretty similar thing. So when EMS basically arrives, those paramedics can give buprenorphine to people. Then they take them right to an outpatient clinic so they can get enrolled into a buprenorphine outpatient program. And then if they don't have housing, they take them right to a tiny home village where they can get housed and be able to have sort of more stability and get onto that road to recovery. So that was a partnership that we've done with the fire department, the Oregon Poison Control Center, Central City Concern, which is that Healthcare for the Homeless organization, and then one of the payers, Care Oregon, that pays for our state Medicaid program, as well as our health department. And then we're working with researchers at OHSU to publish this work. And we're taking a presentation to the American Public Health Association conference in a couple of weeks. So we'll be talking about it on the national stage too. But it's those kind of partnerships, I think, where you have to kind of bring folks together. And when you're talking about academia and public health, I think it's a natural sort of alliance there that you can start to build those partnerships together and really show that this is a very needed way to do that. Um, Now, oftentimes these public health departments need professors, they need folks to kind of teach the students. And so looking at getting a professorship at one of those areas, one of those public health schools is also really a good way to sort of get involved in some of that partnership work. Um, and if you want to stay clinical, there's also opportunities I think in most health departments that have whether it's an HIV clinic or an STI clinic to do medical directorship. So a medical director is also a good way to be involved. Sometimes medical director positions require that you have at least a couple of years of training or a couple of years of experience seeing patients as a provider before you kind of take on the role of a medical director. Most medical directors typically stay clinical somehow. Some do it kind of minimally, um, or sort of like walk-in kind of clinic basis. But those are lots of opportunities to like stay involved and be able to kind of make those changes that we were talking about and from a public health lens within an organization.
Awesome. So this is actually my own question.
Oh yeah.
So what are the pros and cons of working in local, state, or federal public health departments when compared to maybe private sector roles?
Yeah, yeah, it's a great question, Carl. I mean, I think when we talk about population health, for me, it really is trying to impact the most number of people that you can. And so, one of the roles that I played, or one of the rotations I did when I was a PrevMed resident, was I worked at the Clinton Foundation, and so they were working with large employers like Walmart and other kind of large employers where they were helping weigh in on policies for employees who made drug test positive. And so one of the one of the roles I played was helping to sort of um, come up with policies based on evidence, based on papers, based on recidivism and all sorts of return on investment calculations. Where if you have somebody who does test positive for drug use, oftentimes they get fired, right? And it can be really hard for the organization to recover, as well as for the person who's now kind of like spinning potentially out of control there. So one of the the big pitches that we made was getting people into some sort of rehab or treatment is a big return on investment because you can keep them employed you can help them on their road to recovery and help them be more productive employees. If you can invest in trying to help them with opportunities to get treatment. And so that was, one way that sort of like a nonprofit was sort of aiding, corporate company to try and help them think more broadly about their policies. Um, now, uh, from the governmental side, I will say that I get to work on populations that are very large. I said 813,693 people live in Multnomah County. But one of the things that I think is really great about that is I get to think about a wide variety of different communities, and I get to interface with a lot of them very regularly. We have one of the offices we have is a community partnerships and capacity building office. So we have liaisons to many different communities like Native American, Latinx, African American, African immigrant, Pacific Islander. And so we have people from those communities who work at the health department and act as liaisons to those communities. And then I work directly with them to partner on events where I go out into the community with them and talk to them about certain health issues that are really impacting their community, maybe communities that have a disproportionate impact of things like diabetes or fentanyl use. So it really helps me as a government official be able to interface with people that I may not have access to in like a nonprofit or a for-profit role. So that's a real advantage. One thing I'll say about being a government official is that also, I the way our health department is structured is that my boss is the director of the health department. She's the one sitting to my right there. Her name is Rachel Banks in that picture there. She is her boss is the county commissioner chair, and so and actually we're presenting in that picture to the five commissioners at a board of commissioners meeting, and those commissioners have a lot of weight in terms of helping set policy and direction for the health department. And sometimes we can endure a lot of political winds, and those winds can be blowing at us, or it can be blowing from behind us. But oftentimes we have to navigate those kind of political winds and those opinions of elected officials who sometimes play those political games and almost have these this infighting and sort of political theater that sometimes happens among elected officials when they're trying to get their point across or do what's right for them. And so sometimes that can be challenging as a public health official to have to wrestle with that direction with and how sometimes that can abut with what the public health evidence shows and what's really going to be most impactful and beneficial for a community. So you have to weather that. You have to have some thick skin. Oftentimes, you may get criticized. Sometimes I get criticized in the media or by elected officials, and I just try to keep doing the right thing and really kind of keep moving things forward and working with a very dedicated and a, a very dedicated team of people who are really there for the right reasons and really doing this work every single day, and trying to keep morale high among the folks that work at the health department because it can be challenging sometimes, especially we've seen the damage that COVID did to a lot of public health departments, really kind of burning a lot of folks out. So we're trying to infuse a new energy back into health departments so that we can say, look, this work is important. The work that you do, your skill set is really needed right now, especially as we prepare for future outbreaks and things. So I would say that can sometimes feel like a con, but I think there's ways to sort of like navigate those wins so that you can feel like you are still making a big difference.
Thank you so much. I was wondering, what are some career options for those who want to focus entirely on non-clinical work? And I know you touched on this quite a bit earlier too, Dr. Bruno, but maybe in terms of impacting health policy, as you mentioned, more directly working at public political figures, working in public health administration or consulting.
Yes, yeah. So all those are great options for people. I think maybe kind of sometimes hard to get into the consulting biz without having done, a few kind of stable positions in the past where you actually are doing public health policy or weighing in on population health issues. But once you do kind of have some experience in sort of a leadership role, whether it's governmental, nonprofit, or for-profit organizations, that can, I think, really help give you some credibility and some skill sets that can come to bear if you wanted to go into sort of consulting on your own. And there's a number of ACPM members who do just that. A lot of leaders within the college who act as consultants and weigh in, help guide organizations toward better population health management. Um, I would say that right now there's a lot of really big interest in being able to think creatively about using new tools like artificial intelligence in public health. In fact, our college is developing a certification course in AI that any of you can take once we get it ready. Should be done by the end of the year. And we have basically a 10 module certification course that you can watch, and then get a focused practice designation in AI that you can add to your signature line or your resume that will show that you're interested in and certified in artificial intelligence and its role in public health. And really, what we're trying to get at here is help the physicians who are going to be doing large population health uh, analytics or modeling to be able to understand the role of AI and what it will be playing here. It's already come in tremendously handy in a number of jurisdictions. I can tell you, we're looking at a lot of AI projects right now. I was just over at the DC Health Department a couple months ago when I was at the ACPM conference back in April, and they are using AI, real-time AI analytics for their wastewater surveillance. So they can take a look at wastewater that's coming into a certain area of the city of DC, and they can pick up on norfentanyl metabolite levels in the water, and then they can hyper focus their EMS responses in that area geographically. In an instance where maybe there was a bad batch of fentanyl, and a lot of folks have very high levels of fentanyl, norfentanyl metabolite in their urine in that area, so they can make sure they're have the EMS there to respond and save people's lives quickly. And they're using AI to help kind of pick up on those small data blips, And I think that's really one of the benefits of AI is that it can pick up on those spikes and dips in the data trends before we may be able to pick up on those trends with the naked eye. And then we can use population health and predictive modeling to determine best and worst case scenarios and be able to adapt our interventions and strategies around those. So AI is going to be tremendously helpful for things like that. You've already probably seen it being used for AI scribing, for physicians in exam rooms, radiologists using it for picking up on imaging, things that may be missed on imaging, and a whole host of other sort of AI opportunities these days, especially around public health messaging. If we wanted to try and uh, craft messaging for a certain demographic or a certain area of the population that has a certain disproportionate impact of a disease burden or trauma, we can use AI and a large language model and generative AI to help us with that as well. So a lot of really interesting things coming down the line, and I think us in PrevMed are like some of the best poised to be able to sort of understand and start to utilize them in an ethical way.
Thank you so much. We have another question. How can CDC's data modernization initiative and funding awarded to state and local health departments help residents who are looking to begin their career journey in health departments with entirely non-clinical jobs? So speaking of AI and data,
Hmm.
what are the job titles that they should look for?
Yeah, yeah. So let's see. So with a lot of the data modernization work that's coming through, a lot of that has some of that will go toward public health workforce efforts, and oftentimes it's going to be kind of funneled uh, through the IT and the sort of data analyst portion. Oftentimes, it's going through uh, the epidemiology team, for example, and some folks uh, who graduate from a preventive medicine residency may want to focus on epidemiology and typically use that skill set as their kind of main skill set that they would come to bear. And so in those cases, I have a friend who was in my preventive medicine residency. He didn't finish. He didn't complete the residency, but now he's an epidemiologist instead, and he does that work, kind of as an alternative to the medical side. Um, but what I would say about the funding that's coming through is that wherever it sort of lands, I think it's important for PrevMed docs to really kind of weigh in on how it should be best utilized. And so, oftentimes, when you're in a directorship position, you're going to help kind of like identify needs and direct funding toward those needs, whether that's sort of a medical director or a division director or a department director. Um, those are the kind of positions I would kind of look out for if you want to be involved in sort of how that those funding gets distributed, and that's mostly at a health department level. If you're talking about like health and human services or like on the federal level, um, there's a lot of PrevMed docs, working at CDC or HHS or FDA who are uh, the types of job descriptions that they would have may not say director level, but they may have other titles that can help kind of direct those fundings to the right places. And I'm happy to kind of talk through this more with you too. And if you have a desire to want to connect with people who are doing that type of work, there's a whole host of ACPM members who I'm sure would be willing to talk with you about it. I'm happy to connect you if you wanted.
This is more of a general question. How competitive is the job market for preventive medicine physicians, and what can we do to make ourselves more marketable while we're in preventive medicine residency?
Yeah, yeah. So it kind of gets back to that like carving your own path thing. If you are interested in doing something that doesn't exist, obviously trying to create a position is always an option. For example, I was a medical director at Federal Qualified Health Center in Baltimore, and I wanted to take a larger role in population health. So I created a position called the Population Health Department Director, Medical Director, and um, I was able to work more closely with the folks who were doing sort of population health and more preventive services, like bachelor level employees who were encouraging uh, patients to get their mammograms and get their colonoscopies and do their preventive services as sort of like healthy behavior nudging for the patient populations, and they worked sort of in tandem with the physicians and their teams of providers to be able to uh, not only sort of analyze like what who's doing kind of the best work and like who has the highest number of colonoscopies. Well, it's Dr. Smith because she's able to talk with her patients about how easy it is to get a colonoscopy, fecal occult blood test done, and then she has her MA like hand it to them right while they're in clinic or mail them the card or whatever it is, and so her numbers are way higher than a lot of her peers. And so you can do a certain amount of population health analytics and what we call kind of bright spotting, where we see like, why is this population doing better? What are the trends, and how do we sort of highlight those actions on the behalf of the healthcare team that are enabling people to like actually take advantage of these in better time? So that kind of population health uh, department within the clinic was really a great way to sort of continue to analyze those statistics and then also kind of like apply those back across the bell curve there and improve for everybody for the whole census. So to say like you can sometimes create your own position and choose your own adventure. And oftentimes, I think what if we get to like the sort of the competitive nature, yes, I think there's positions like health officers that are very much needed, but sometimes competitive among kind of local docs who want to do that kind of work. And so things that can set you apart and kind of give you an advantage are um, really it's just kind of the experiences that you've had both clinically and population health wise, but it really I think it's talking about the mindset that you have, and it kind of gets to a little bit of that public health journey mindset that I mentioned kind of there on the slide, is really thinking about how you're going to incorporate a wide variety of data, thinking broadly about social determinants of health, about being an advocate for your patients and an ally, and then utilizing those problem-solving skills and those tools in your toolkit, like the epidemiology and the biostats and the program planning and the budgeting and all the classes that you've taken those core competencies in your MPH courses, and bringing that to bear, thinking about the large public health problems like racism that still makes it very challenging and still causes a lot of health disparities among so many of our populate folks in our population, and how you sort of wrestle with all this kind of like simultaneously, right? And so you really are just trying to sell yourself as somebody who thinks broadly, but also has like some deep fundamentals, and then has been able to sort of like carve your kind of niche out, whatever that is, whatever kind of passion that you have, whether it's addiction or something else, whatever, however you've been able to sort of like implement this work across your population. It's just kind of like putting that package together, selling yourself as an incredibly valuable uh, leader in this field, and yeah, and just finding ways to make it work. So uh, yeah, keep up the good work. Like keep finding ways to like do this work, and explore these relationships and learn from others about how they've done it in the past, so that you can put together sort of the best package that you can to present yourself when you're applying for positions.
Thank you so much. Speaking as a resident in ACPM, I can say that ACPM definitely offers a lot of events, job boards, mentorship opportunities. And in fact, I think Anita was about to share a job website at the end. We did have a question. How can preventive medicine residents advocate for themselves to get hired into jobs that fit their skills, but the job is open only to other specialties? In other words, what should residents do if we come across job descriptions from employers that are not aware of preventive medicine?
Mm, yeah, that's a great question, and I like to use opportunities like this to sort of inform the folks who are reading these applications, and the folks you may interview with if you get that far, to about what preventive medicine is and how beneficial it is to have somebody with a public preventive medicine mindset and this public health mindset, because it sort of guarantees that you come with a certain amount of skills. It guarantees that you have had some experience, in your rotations or after graduation, and it encourages them to give you the chance to explain your perspective on how you approach being able to wrestle with these disparities and how you can directly address things like racism in communities. And so I would say, yeah, use preventive medicine as an amazing tool to help address what so many different specialties really need right now, and that is like very upstream approaches, midstream approaches, and sometimes downstream approaches to tackle these very complex public health problems.
Thank you so much, Dr. Chatpar and Dr. Bruno. I know we only have a couple of minutes left, but I do, because of the questions that came in, I do want to just quickly say that this is only one of many events that we have planned, yeah, and we will continue to have these kinds of sessions throughout. Please join us for sipping session next week. It's a purely networking session among members. in the evening on October 23rd at 5:30. Again, this is a wonderful opportunity for all of you to network with one another. I'm going to quickly paste the registration link in the chat for both these events. The other event we have, especially for residents, is the networking, the resident and early career physician speed mentoring event. That's going to take place on November 14th at 6 o'clock. And again, that's specifically for residents and early career physicians to, get to know one another and expand their network and ask questions about the specialty. Please feel free also to join the various sections that we have in global health, pharmaceutical health, and as Dr. Bruno mentioned, artificial intelligence and digital health is also a very important specialty area of focus among our members, and they've really expressed an interest here. And so please feel free to join any or all of the sections. Information is available on our website. I did want to just point out here, we have a QR code with ACPM's online career center. I do think this is a work in progress. I've recently taken over the management of the career center. We've stopped, posting of any jobs that are not relevant for preventive medicine physicians, but we're also constantly thinking of ways in which we can optimize, the career center to have more preventive medicine focused jobs. There is currently a job posted from Dauphin County for a public health physician. Speaking of jobs in public health, so please take a look at that particular job posting in the career center to see how the positions are described specifically for. So you may not see preventive medicine physician itself. You may see titles like health equity officer, public health physician, data information systems officer, and social determinants of health, etc. So we see so many different titles. So you may just have to dig a little bit deeper into the type of titles that's offered in the ACPM Online Career Center. And we're constantly seeking feedback from our physicians and residents to see what kind of titles we should look for so that these jobs can be added to the Career Center. Again, it's a work in progress. Your patients as we try to make this a #1 destination for all preventive medicine jobs. And with that, Dr. Chatpar, I'll turn it over to you. I think there's one more question that came in.
Oh, I apologize. What approaches should be taken to convince health systems to hire preventive medicine physicians to be given the time to do this work and not on top of or in addition to having a full clinical workload?
Okay. Yeah, this is a good question. I think that right now a lot of health systems have a chief medical officer or a medical director who is already wrestling with population health management and with preventive medicine, but they may not have the skill set or they may not know much about preventive medicine. So oftentimes there's a gap there, is what I'll say. Um, so what I would say is, if you're talking with a health system about the work that you're doing as a preventive medicine doc, and I will say a non-clinical, um, that there's ways you can sort of convince them that this work is important and it's important to hire you to do this work, regardless of whether or not you'll stay clinical, because oftentimes there's such a huge need, especially in these larger health systems, that you will be very busy, working on population health stuff without necessarily having to do clinical. Um, Now, if you're talking about sort of carving out like your schedule, a lot of times folks will do kind of half and half, especially when they kind of start out. They'll kind of do half clinical and half administrative. And then over time, a lot of folks kind of pare down the clinical piece and do more administrative pieces. So it's just a balance, and it's just like it's just something you have to kind of have a conversation with those systems about. Um, but it kind of depends on what you want to do, and then just sort of selling yourself as like somebody who can meet the needs of the organization in the role that you plan to play.
Well, thank you so much for this very insightful and an engaging question and answer session on preventive medicine careers. Dr. Bruno, I feel your expertise and passion for preventive medicine is really inspiring. Mentorship is extremely important in this kind of field where we are carving our own path, and I think we all need that to lean on. So we were able to gain really valuable knowledge, and I'm sure that this will benefit us in our professional journeys as we carve out our careers.
Yeah, best of luck and stay in touch. Anything I can do to help. Thanks, Dr. Chapar. Thanks, everybody.
Thank you.